Hello, everyone. Today, we're going to be talking about the use of platelet rich plasma in elbow tendinitis. First of all, what is elbow tendinitis? So, it's a broad term which can refer to two different or three different pathologies. One, the first one on the left is a diagram showing the common extensor origin. And this is basically the lateral epicondyle. You can see the extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum communis, and extensor carpi ulnaris. They all insert from the lateral epicondyle. On the medial side, you have the common flexor origin, which is corresponding to the medial epicondyle, giving rise to the pronator teres, flexor carpi radialis, flexor carpi ulnaris, flexor digitorum superficialis, and palmaris longus. The third type of tendinitis around the elbow is basically where the triceps tendon inserts, but we will not be discussing that today. The clinical presentation and initial management. Generally, the symptoms will be pain on one or both sides of the elbow. It's usually exacerbated by activity. It's usually seen in middle-aged people, especially the people who are performing repetitive actions around the elbow as part of their day-to-day activities. This pain is usually relieved by rest, although there can be a point of time where the pain is continuous and present all the time. Patient may also complain of weakness in extending or flexing the wrist. As for signs, the most common sign is tenderness around the medial or lateral epicondyle. Medial inflammation around the common flexor origin or medial epicondyle is called golfer's elbow, and inflammation around the lateral epicondyle or the common extensor origin is called tennis elbow, which is a lot more common. So you can have tenderness on either of these epicondyles. There are then uh, tests that we can do. We can do resisted wrist flexion to test for golfer's elbow, which is called the reverse Cosen's test, and resisted wrist extension to test for tennis elbow, which is called Cosen's test. We have also have other tests where you check for resistance on extension of the metacarpophalangeal joints. This is called Mills test. So, what exactly is platelet rich plasma? Basically, if you take blood and you run it in a centrifuge, the blood will then separate out into three layers. The top layer will be plasma, which is relatively poor in platelets and rich in proteins and clotting factors. The middle layer will be the platelet rich plasma. And at the bottom, you'll have the red blood cells, which would have sedimented at the bottom. Now, platelet-rich plasma, on top of being rich in platelets, is also rich in lots of growth factors, such as platelet-derived growth factor, transforming growth factor beta, and vasculoendothelial growth factors. These factors have been shown to play roles in both healing and inflammation. This slide shows an ultrasound examination of the lateral aspect of the right elbow. Uh, you can observe on the left-hand side that white rim is the lateral epicondyle. The white area in the middle is the humerus. Now you can see the radial collateral ligament and the common extensor tendons at the top of the image. Muscle generally appears as blackish or grayish, as opposed to white, which is more bone, which is white. You can see the radial head on the right hand side. On this slide, you can observe the normal and abnormal orientation of muscle fibers, uh, or tendon fibers to be more specific. So on the left side, you can see there's a nice straight parallel gray orientation of the muscle fibers at the top of the picture and on in the area where the common extensor origin is. On the right hand side, you can see we've zoomed it up. You can see discontinuation and disorientation in the parallel um, direction of the tendon fibrils. This basically is the ultrasound finding of disorganization around the tendon fibers and is the most common sign of inflammation and epicondylitis that you will get when performing an ultrasound. So, what we follow at Torbay Hospital in Devon is a patient is either is with elbow tendinitis is usually managed initially by the physiotherapists, and the management is usually started with activity modification and splints. If the symptoms do not improve, they are then referred to the elbow tendinitis clinic, where we evaluate the functional deficit and pain in the elbow using the quick dash scores. We also perform an elbow ultrasound. If we get convincing signs of tendinitis on the ultrasound uh, with disorganization of the parallel um, tendon fibers, we then explain to the patient the benefits of PRP infection, the risk of recurrence, the other treatment options available. And if they agree for a PRP injection, we take their blood, centrifuge, generate the platelet rich plasma, inject their under ultrasound guidance into the area with the maximum disorganization, and sometimes neovascularization when you turn on the Doppler mode of the ultrasound. And we usually follow them up either by phone or face to face at 3 months' time for repeat quick dash scores. So, what were our experiences? 350 plus patients have been seen over 12 years, starting in 2013. This was when the NICE released guidelines authorizing the use of platelet rich plasma uh, for the treatment of elbow tendinitis, both golfers and tennis elbows. From 2013 to 19, we did 265 elbows, 178 patients received single injection, and 87 received more than one injection. There was a minimum 1 year follow up. Often, patients did not improve or had slight improvement after one injection and agreed for a subsequent injection. And often, after two, three, four injections, patients started getting lasting relief. Another thing that we noticed was when we do the repeat ultrasound scans, we looked for signs of neovascularization, which is a sign of healing. The absence of neovascularization was usually a worrying thing for us because it often pointed to a burnt out disease with minimal potential for healing. There was a minimum of 1 year follow up. The average quick dash score was 54.9 pre-injection and 29.4 post-injection, with significant improvement on the score. Both tennis and golfers elbow patients improved equally well. The best effect size of improvement was when the initial score was between 50 and 70. So the quick dash, just to summarize, is a score which looks at the function of a shoulder and um, elbow. It can be used for either of these. 100 is the most severe disability, and 0 is a completely normal and functional elbow. We found that patients with initial scores between 50 and 70 did the best. What we mean to say is that if it was a very, very severe case, it was less like with a very high quick dash score, it was less likely to get significant improvement. And if it was very, very mild, it was also less likely to get significant improvement. 11 elbows in this period did not improve and required surgery between 2013 to 19. And this was a massive reduction in the number of surgeries we did for this condition. Prior to starting these injections, we used to operate 12 to 15 patients every year with refractory elbow tendinitis. Another thing that we found was that often patients who had surgeries who were not happy with the results after several PRP injections started getting lasting benefits and reduction in quick dash scores. So we can use PRP even in cases of failed operation. What is the evidence thus far on the use of PRP injections for tennis and golfers' elbows? First of all, it's very, very controversial. There are lots of studies, often showing contradictory results. There are no true randomized controlled trials um, or very vigorously designed studies. Most of the studies are non-randomized studies and case series. NICE guidelines in 2013 authorized the use of PRP for tendinopathy. They based this on three randomized controlled trials looking at 350 tennis elbow patients. It broadly showed at least a 25% reduction in visual analog score for the pain and no reintervention in between 66 and 77 patients. And they were comparing this with steroid injections for the same condition. Mishra et al. In 2014, in a study with 230 patients, showed that there were differences between chronic tennis elbow patients who had needling with or without PRP at 12 weeks, um, at 24 weeks after the injection, but there were no significant differences at 12 weeks. Uh, he used a leukocyte enriched platelet rich plasma. Krog et al. Found no difference between PRP, glucocorticoid, and saline at 3 months. They found that steroid had a short term pain reducing effect at 1 month post injection. The last study by Yen Wong et al. Was a systematic review looking at 20 RCTs with a total of 1,520 tennis elbow patients. Uh, they compared physiotherapy, steroid injections, PRP, whole blood, and surgery, and could not find very compelling evidence to recommend PRP therapy for tennis elbow. The issues with the evidence is everyone used a different formulation of platelet rich plasma with different centrifuge speeds and different settings. There were different injection methods. A lot of the studies did not use ultrasound guidance to aim the injection in the site of maximum disorganization, often just going blind. There were different follow up periods. Some were uh, 3 months, some were 12 months. There was no standardization in follow ups. And there were always different control arms against which they were comparing PRP. Some would compare with the placebo, such as saline. Some would compare with the steroid injection. Some would use whole blood. So the evidence is very, very heterogeneous. I hope this gave you a useful snapshot into the use of platelet-rich plasma in the management of tendinitis around the elbow, namely golfers and tennis elbows. If you have any questions, please feel free to leave it as a comment. Um, and we hope you found this video useful. Thank you.